I'm happy to introduce Dr. Robert Lennon, who is going to be our moderator today. Yet another general in our presence.
Welcome. Boy, this has been some conference, hasn't it? Boy, as a chordoma patient, I'll tell you, I really appreciate it, what you all have done, and these gentlemen for giving up their Saturday with their families. I'm sure some of them may be taking a little heat at home, but fellas, we really appreciate what you're doing and what you're doing for the chordoma community very much. This conference, when the first exploratory email went out from the executive dean, you know, it was kind of like, could we have this conference? And within the hour, we had volunteers. Mike O'Brien immediately offered his experienced conference planning team. And they do this for patient education, so that's not a rare thing. That's their job. They just finished up doing a melanoma conference, which was outstanding. It was reported to be the best one they ever had. So when Mike did that, I knew Josh. I knew I could handle him. I knew I could get Heather here and Shannon. And sure enough, when he picked up the phone, he was, go for it. So with these two teams coupled together, you know, I thought, man, we're off to a good start. Then, figuratively, we hit a home run when we got our course directors, Dr. Ivy Peterson and Dr. Mikey Yozemski. I knew then that we were going to have a fantastic conference. Why? Because I knew they could and would recruit outstanding, seasoned chordoma experts to come to the small town of Rochester. And they did. Look who we've got up here. Go through the bios. Don't go through mine, go through theirs. I'll introduce them to you. Radiation oncology. We have our special guest from Boston, Dr. Tom DeLaney. Where is he? Oh, there he is. And Dr. Robert Foote. And Dr. Foote's in charge of the radiation oncology, and we're going to go over to see his beautiful new Proton Center later this afternoon. And I'm telling you right now, the artwork in there alone is worth the trip over there. It's just incredible. It's all donated to Mayo, so it's just really nice. Medical oncologist Scott Okuno, there he is, right there. Immunologist Dr. Peter Wettstein, there he is, right there. And then representing the Mayo skull-based tumor care teams is a neurosurgeon, Dr. Van Gompel, and his surgical colleague, ENT colleague right here, Dr. Janus. So what happens when they do these procedures is Dr. Janus does all the work, getting them exposed so that they can get down there, and then Dr. Van Kamp takes care of the rest. We have another surgeon here, neurosurgeon here, Dr. Bydon. Dr. Bydon works on the other end. He works with the sacral teams, and he's kindly down at the end. And let's see, who else? Oh, yeah, the orthopedic oncologist. I have a slight relationship with him. Dr. Peter Rose. And then originally from a small mining community in Nova Scotia is Mayo's Dr. Frank Sim. And I first started working with Dr. Sim in 1980. So we go back a while, and anything I know about chordoma sarcoma came from Dr. Sim. Now I've got a lot of questions. I've got questions that were prepared ahead of time, as well as the questions from the audience. There's no way I can go through all of these. Reading the questions that came from this audience, if we don't get to them, please call Shannon. Call her. I could see from the rating on some of these that you're desperately seeking an answer, and I don't know that I'm going to be able to get to them, because I don't want the fellows to give a partial answer. I want them to give the whole, whatever they need to say. So let's start out with initial treatment and surgery is one of the categories that Shannon gave us. The two pillars of care for chordoma are surgery and radiation. So the first question, and probably our surgeons want to lead off on this, is when is surgery alone an accepted treatment option?
I think surgery has been our default option for treating chordomas really since the era of CT scans came about in the 1970s. And so with really 4 decades of experience, I think we've all come to understand the strengths and the capabilities, but also the limitations of surgery. As we look at surgery as an option, if we can achieve a truly wide oncologic margin around a tumor, then the likelihood of good outcome, I think, remains excellent for patients. The trouble is whether the price that wide margin comes at and whether the local anatomy and geometry allows that. So if we have a tumor which is in the sacrum where it is reasonably contained and in which we can truly achieve a wide margin around that, particularly the lower sacral tumors, I think there remains an excellent role for surgery and to hold radiation in reserve for those patients. The issue really becomes the morbidity that's associated with those in the long term for patients, in the neurologic sacrifice and the loss of bowel, bladder, sexual, and potentially ambulatory function as we look at higher and higher levels of resection, or tumors which are so locally advanced that there really is no possibility of achieving a wide margin around it, or which have invaded adjacent organs. Surgery is almost certainly going to be ineffective, or I should say, not ineffective, but an incomplete treatment for a tumor of that nature. And so there's going to always be a need to individualize the role of surgery and advanced radiotherapy techniques in patients. I think as we hit the mobile spine or the more locally advanced tumors, that as we move to that domain, I think the role of adjuvant radiotherapy becomes more and more important in the management. That said, I think if we're still looking at a low tumor, S4 segment, something of that nature, that we can get around well that doesn't have locally invasive characteristics, we can get a great option on. And even as we move into the higher tumors in the sacrum, we're below the nerves that disrupt ambulatory function, those remain a good option. Radiation is a tremendously powerful tool, but it also has some negative effects, and so it's necessary to balance these for every individual that we encounter.
I'm going to contrast that to skull-based chordomas. I think, and I don't know if some of the other panel members would agree with this, but I think for whatever reason, the skull-based chordomas are the same yet a different animal than the spine chordomas in many respects. The biggest one is whether or not we can actually achieve en-bloc oncologic resection, which is really not how skull-based chordomas are managed. They're more often intralesionally removed, and then at that point in time, if we're capable of doing it, we'll then take out as much of the margin as we can safely up to critical structures. But there's definitely an awful lot of critical structures of the skull base which limit the resection. So it's very common, at least in our, and at least the tumors that we take care of, that we would then go on and recommend that patients get radiation after. But that being said, there are a number of patients in our series here, and recent patients that have had very small incidentally found chordomas that we're very comfortable with a very good resection, that have heard the talk from our radiation oncology colleagues and have chosen to observe them. And there's certainly a number of patients that do that. That's not my recommendation, though. I don't think it's a good strategy for this tumor based on what we know from the past.
If I can make a comment on that. First, to echo Dr. Rose's comments, there may be a role in the spine, but for the most part, you're going to have radiated tumors that are getting radiated after resection with a possibility also of pre-op radiation, which Dr. Rose and our oncologists have been, and Dr. Sim have been leaders in here. The other thing to consider, as Dr. Van Gompel was saying about the critical structures, so in the sacrum, for example, if you think of the critical structures there, anteriorly you've not only got the iliac vessels, you could have injury there, but you've also got the rectum, you could have injury there. You've also got the nerve roots, which may have to be sacrificed. So the challenging part of these surgeries is you not only have to think of the critical structures, but then once you remove the tumor with as much preservation of those critical structures as possible, how do you reconstruct? And that's an area that here we've been doing a lot of work in. We're going to be presenting that at the North American Spine Society next week in Boston. Those are just kind of things that you want to think about, and many of you have probably done a lot of research on this already. And I'll just add one comment. I recently came here from Johns Hopkins, and I've been unbelievably impressed and humbled to be working with people who have as much expertise as they do. So at Hopkins, when we put together the surgical reconstructions, the ones developed by Dr. Yozemsky, Dr. Rose, and Dr. Sim, it actually ended up being the majority of all the different reconstructions, and much of the work that we did was building on the work that they've done and continued to pioneer.
We'll move on to the next question. Pre- and post-surgical radiation. Question is, when is this approach used, and is it appropriate for skull-based, mobile spine, and sacrum?
I can comment on this. We have adopted and recommended this approach for patients who we feel need radiation as a component of treatment for mobile spine and for sacral tumors for several reasons. The first is that surgeons are often operating in close proximity to the tumor, and whether they get into tumor, or we know chordomas can involve lymphatics, so you could have tumor cells in the lymphatics beyond the tumor you can see. In radical surgical specimens, we have identified implants of chordomas in gluteal muscles. Sometimes you have patients who have a large tumor, they're sitting on the tumor, they're putting mechanical pressure on the tumor. So this is a means of essentially sterilizing the tumor such that any tumor cells that are spilled into the surgical cavity cannot implant. And one of the things we've learned is one of the classic approaches in radiation oncology was in fact developed by Len Gunderson here at the Mayo Clinic, who was head of radiation oncology here, was called patterns of failure studies, where he looked in patients with gastrointestinal tumors, and he started doing this as a medical student. It was remarkable, looking at where tumors recur after surgery alone. And when you look at where tumors would recur after surgery alone, it was often, at least for chordomas, in the surgical bed and in kind of a U-shaped area that extended from what we call the ischial spine, the back of the ischium, across the muscles and ligaments that extend from the spine to the sacrum and on both sides. And again, those are sort of natural routes of spread of the tumor. So I think if you can deliver some radiation to these areas before the area is surgically manipulated, it appears to address this issue of implantation in the surgical area. The radiation dose that we've used has been sort of tailored to what the risk of wound healing complications is. Sacral spine surgery is big surgery, often in an area that's hard to keep clean and has a higher rate of wound healing problems. So for some patients, we'll use a radiation dose of just 19.8 gray in 11 treatments. For patients with mobile spine, we tend to use 50.4 gray in 28 fractions, surgery about a month later, and we deliver some additional radiation dose to the tumor bed itself, again, related to the fact that you need a higher radiation dose, and it's difficult to give the entire radiation dose before surgery because of the risk of wound healing problems. But this approach appears to provide local control in a very large proportion of patients. In some patients, it may allow a more conservative resection, the kinds of patients we're seeing in whom they get pre-op radiation and en-bloc resection with the narrowest of margins, less than 1 millimeter, and this post-op radiation boost. We're seeing virtually no local recurrences unless the patient has had some event before surgery, such as a pathologic fracture where they've had bleeding into the tumor and tumor cells have sort of spilled out into the area around the tumor. But those are our rationale for that. And the last thing, some component of pre-op radiation allows you to use smaller radiation fields. The radiation fields are smaller than in post-op radiation. You have to address the surgical scar, drain sites, and as well, at least in the sacral area, if you're delivering all of the radiation post-operatively after sacral surgery, for example, bowel can herniate into the area, and the radiation dose that's required to sterilize chordomas is higher than bowel tolerance.
Anyone else care to comment?
I don't know if Dr. Foote wants to comment on this, but for skull-based chordomas, pre-op radiation isn't very commonly employed, just to clarify. And one of the reasons is that a lot of times they're compressive tumors, and one of the most important things post-operatively is how much we're able to actually get that tumor cleared away from the brainstem, and the brainstem relaxes into that cavity. So that's one of our primary operative goals. I don't know if, Rob, if you want to touch on that a little bit too. But again, pre-op radiation for the skull-based ones isn't very common.
Yes, that's true. And one of the limitations we have with radiation therapy for skull-based chordomas is the proximity of the cranial nerves and the brainstem to the skull base. We worry about brain necrosis, brainstem necrosis from the high doses of radiation. So it's advantageous if there is extension up against the brainstem to have that removed to give us a little safety space to work with. So the brainstem gets a lower dose while we can still give a high dose to the remaining skull base. And we worry about the dura not healing, getting a CSF leak and meningitis if we give preoperative doses of radiation to the skull base area at least. So we tend to give almost exclusively post-op for the skull base chordomas.
I'll say another interesting part about the skull-based tumors is our reconstruction oftentimes is designed to keep the brainstem as far away as possible from that operative site. And also, it's very common for us not to be done with our surgeries until the radiation oncologist tells us we are. That's very true.
We have a follow-up question from the audience. Are there risks for wound healing complications with preoperative radiation for sacral tumors? Dr. DeLaney's touched on it a little bit. Let's go with it a little bit farther, fellas.
There are, and I think like anything in medicine, we weigh risk versus benefit, and whether something is a transient issue or whether it's a permanent issue. When we have looked at patients who've gotten preoperative radiation, for unselected patients, there's a higher risk of wound healing complications with 50 gray of preoperative radiation compared to 19.8 gray. And the risk of complications with preoperative radiation of 50 gray is about 40%, with 19.8 gray is about 30%. But with surgery alone is probably in at least the 25% range. So it does appear that you can address that. Some techniques currently for improved reconstructions using rectus flaps, using anterior rectus muscle flaps are ways of providing more robust closure. And at least as wound healing science improves using some things called vacuum dressings and flaps, skin grafts, one can often address acute wound healing complications. And at least when you look at the big picture, a local recurrence of chordoma is a very difficult problem to manage. And I think if you are able to combine surgery and radiation in a way that you can prevent that, I think that's the optimal care for the patient. And again, it's part of working very closely with the surgeons. We, for example, look at the anatomy of the tumor. If from a preoperative radiation, if it's not involving the subcutaneous tissue, we don't treat it. We're really looking at just the chordoma and treating not any more superficial than what's called the investing fascia, again, to try to reduce the rate of wound healing complications.
Surgeons, no comment?
I would just agree, and I'd also echo that, well, infection and wound healing complications are the most common difficulties that we face in the near to intermediate postoperative time frame. You know, you're in it for it's for the 5-year, the 10-year, the long-term outcome. And so, you know, when you have a wound healing trouble, it's frustrating for everybody involved, no more so than the person whose wound isn't healing. But if it happens, then you grit your teeth and you get through it, and you do get through it. And so for those cases in which radiation is an important part of the treatment, we recognize that the risk of wound trouble is going to be higher. But as we balance that out against the long-term benefit, that in those patients, the benefit's generally there.
We have some more surgical questions, but I'm going to move on to ask a few questions of radiation oncology. We'll go back to the surgery questions later. The first question for the radiation oncology, Dr. DeLaney and Dr. Foote. Radiation alone, is high-dose radiation appropriate as an alternative to surgery, and if so, when?
I think it can be a treatment option for some patients, and as I had discussed earlier, we try as much as possible to evaluate patients in a multidisciplinary setting where we have both surgeons and radiation oncologists present. And I think patients where I think radiation alone would not be the favorite option would be patients who, for example, have, I think some of the patients we're most concerned about are patients of upper sacral tumors. So I think if someone has a distal sacral tumor, so S4 or a coccygeal tumor, we always, in patients who are medical candidates for surgery, include surgery as part of the treatment because you're not going to have the neurologic sequela of the sacral resection at that level. But tumors from S1 to S3, where the sacral resection will impair anal and bladder sphincter control, for patients who have already lost that sphincter control as part of the tumor process, they present with locally advanced tumors. Again, I think trying to use radiation to treat their tumor where they've already lost that sphincter function, there's not a compelling rationale for that. But patients in whom that sphincter function is intact, I think those are patients where one can discuss the option. And as I say, we're gathering experience with protons where it's looking about 5 years, perhaps 80 to 85% of patients will have their tumor locally controlled. We're still trying to get 10-year data, although the carbon data is a little bit sobering at 10 years, where at 5 years it might be 80%, at 10 years it's about 50%, although I think that may in part be a function of the fact they're only treating the gross tumor and not some of the adjacent pathways of spread. So I think their target volumes may be an issue. But I think for the patient needs to be engaged in the discussion in terms of the quality of life issues versus the control of the tumor. I think from a point of view of control of tumor, the combination of pre-op radiation, en-bloc resection with a negative margin or at least only a microscopically positive margin of post-op radiation appears to have a higher rate of tumor control than radiation alone, at least at the current dose as currently given. But if it's going to have major impact on quality of life, I think that we're really trying to address the concerns of the entire patient. One thing at least is intriguing to me is that in many other tumor sites, the combination of localized radiation and systemic treatment, chemotherapy, or at least in some areas like head and neck cancer, where you're targeting growth pathways, the epidermal growth factor receptor inhibitors, local control is improved with a combination of systemic treatment and radiation. And that may be enough, hopefully, in the future to allow us to improve the treatment, the non-surgical treatment. So these are, I think, areas for further investigation. One thing that we are trying to do, again, as part of the sacral tumor study group, is trying to collect quality of life information, because radiation alone can also have long-term impacts. Patients can have late sacral fractures. A small proportion of patients have had radiation dysfunction or nerve dysfunction related to the radiation. Some other things we're trying to explore is, as we move towards the scanned beam and painting the dose, is trying to give higher doses in the center of the tumor, away from the nerves. We've also looked at, we've documented that some chordomas are what we refer to as hypoxic. They have low oxygen levels in the tumor, and radiation works by generating oxygen-free radicals. You need to have the oxygen there. So in areas of, you can do scans, nuclear medicine scans called F18 misonidazole scans to look at, document where hypoxia is and try to put more radiation dose into that area, again, an experimental approach. And the last, of course, is there now, at least in sarcomas, other mesenchymal tumors, beginning to look at combining radiation with immune checkpoint inhibitors. The first studies are just opening, and we're hoping that those studies are now being addressed for patients with recurrent chordomas. If this is an active approach, one can look at combining immunotherapies with a definitive radiation, because as Dr. Wettstein mentioned, if you are able to kill tumor cells, lyse them with very high dose radiation in the center of the tumor, you release tumor antigens, and if you've primed the immune cells, the T cells, they in fact can then trigger a much stronger immune response.
No takers. Okay. The next question is, we have some terms that we hear as laymen, and it's a bit confusing. And for instance, pencil beam scanning, spot scanning. This question comes up, what in the world do these things mean, and what do they mean for a chordoma patient? When you say, well, you're going to have radiation, and then you hear this stuff, and if you're like me, you went to Dallas Airport last week, and here was signs promoting proton beam therapy, and they're spouting about pencil beam scanning and all that, and everybody, oh yeah, I want one of those, I want to buy one of those. So I don't know what the heck half of this stuff means, and but we have two experts here that do, and Dr. DeLaney and Dr. Foote, and they have some slides that they'll share with us to kind of help visualize what these words mean and why it's so important and why it is an amazing advancement for our care. Dr. DeLaney, I think this is, do you have slides? Maybe.
There's we'll see whose slide it is. Put the slide up.
Put it up.
Oh, I recognize this one. I probably stole it from Dr. DeLaney out of his textbook. So the standard conventional way of administering proton beam therapy is something called passively scattered proton beam, and that's the top panel. And over on your left-hand side, that blue line is the proton beam. You see it starts off relatively small, about the size of a pencil or a pencil lead. But then it goes through a scattering system that scatters the beam and makes it as large as a tumor. Way over on the right-hand side, you have the yellow body and the green tumor in it, and then some critical green structure sitting next to it. But that scattering system scatters the proton beam to make it as large as the tumor dimension. And then Dr. DeLaney showed you the brass collimators that shapes the beam to the same size and shape as the tumor. And then he also mentioned that compensator bolus or range compensator that modulates the energy of the beam. The higher the energy, the deeper it goes, the lower the energy, more superficial it is. So on top of the green critical structure, we want the beam to go deep and get all of the tumor. So the compensator is relatively thin there. But right over the critical structure, the green thing, we want the protons to stop before it gets to the green. So the compensator is thicker there to absorb more of the beam and slow it down. This is the traditional way of treating with a passively scattered beam. Some of the disadvantages are those collimators are made out of brass, and so you have to have those manufactured, and that's additional cost. And when the protons hit the collimators, they become activated, they become radioactive. So once you're done using them, you need to store them away somewhere for a while till they're not radioactive any longer. And then the compensator boluses, you have to manufacture those too. And then often we'll treat a patient not with just one beam angle, but maybe 2 or 3 or 4 beam angles. So the therapist has to go into the room, put in a collimator, put in a compensator, go to the angle, leave the room, treat the patient, go back in, take the collimator, the compensator out, put a new collimator, a new compensator in, and repeat that 2 or 3 times. So as all of you know, you're lying there on the table immobilized, and it can, you'll end up spending more time on the table. So on the bottom panel is the pencil beam scanning. The red line in this case is the proton beam, and it stays that small size, 2 to 5 millimeters in size. And the blue panels, the marked X and Y, those are magnets. Since the protons are positively charged, we can use magnets to move them back and forth and up and down and just scan that pencil beam throughout the tumor. So the tumor target is here on the right side. So we send the protons in first with a very high energy, so it goes to the deep part of the tumor. And then we use those magnets to move it back and forth and up and down to treat the deep slice of the tumor. And we back off on the energy of the protons, lower energy, so they don't go quite as deep. And we treat the next layer of the tumor. And we just keep backing off and treating the tumor slice by slice till we get to the superficial aspect of it. Right now we are painting discrete spots. We'll treat a spot at a time. But the newer technology is treating in lines, so it goes by faster. And the latest technology is something called multi-energy extraction, where you can extract multiple energies of protons out of the accelerator and paint multiple slices all at the same time. So it's a quicker treatment. You're not lying on the table immobilized as long. And we don't have to worry about the radioactive collimators. We don't have to have the therapist going in and out of the room. They can just move the beam around. And it reduces some of the costs because you don't have to fabricate the collimators or the compensators. So in a nutshell, that's the difference between passively scattered beams and pencil beam scanning.
The other comment I would add to that, and it was a very nice description by Dr. Foote, is as you are scanning the beam, you can decide you want more dose in particular areas. So for example, I'd mentioned we have a wider field that we treat where there may just be microscopic tumor cells that have spread beyond the chordoma and then the tumor itself. So you can put more dose into the tumor itself. You can paint more dose into an area where the surgeon might feel he might have a harder time getting an adequate margin, like perhaps against the iliac vessels, for example, of tumor extending anteriorly, or an area which might have a low oxygen tension. So this is really a very important development in terms of our field, in terms of it's all about putting the radiation dose where the tumor cells are and trying to get as much radiation in there. This technique also gives less dose to the tissues in front of the tumor. It's a very important technique. And the facility here was designed with this capacity in mind. And I know we're having to retrofit our facility for this. So one of our 2 gantries is currently scanning. The second one will go completely scanning later this year. And we're adding another room again, which is a scanning facility.
So I was going to ask the question, is it the type of system that you use dependent on where you go, the location? In other words, if I go to MGH, I might get one kind. If I go to Memphis, they may do another.
That is potentially a difference in terms of what the technologies are. One other sort of very subtle thing is that because protons only go a certain distance and stop based upon their energy, you have to have systems in place for what we call robust treatment planning and delivery. So first of all, the patient, you have to understand the motion. If a target is moving, you have to understand that, and that's harder for a scanning beam. The other, if the tumor changes over the course of the treatment, and if, let's say, there's some necrosis of tumor and it expands from related to just edema in the tumor, for example, then your protons might not go far enough. So I think one has to also be aware of any changes in the tumor and develop what's called robust treatment strategies to address that. And this is something we're actually used to. We sort of manage uncertainty. It's something that we're used to with conventional or intensity modulated X-ray treatments, but it's more important for protons because the particles only go a certain distance and stop. So you have to have very complete understanding of how to manage that.
Not only do you have to pay attention to changes in the tumor throughout the course of treatment, but also changes in the patient. If they gain weight or lose weight, the protons are going to end where you hadn't planned them to stop. So you have to pay attention to that too.
That was going to be my next question. We know that we do the tattoos for those of us who have sacral, and you use the mask for those who have skull-based radiation. And the question is, how accurate can you send this energy, and how reproducible is the position of the patient? You know, you do it, and then you do it, and then you go back the next day, and you come back the next day, and you come back the next day. And each time you come back, there may be a different technician there. So what is, I guess the word would be accuracy, or reproducibility would be the word.
The specifications for our gantry that rotates the beam around the patient and the robotic patient positioner are less than a millimeter. And that's something we can measure at the isocenter where those protons are stopping. And so we're at about 0.7 millimeter, 0.5 to 0.7 millimeter accuracy. Now patients move, and so we allow for that movement as part of the robustness. What if the patient moved so many millimeters in this direction one day and so many millimeters in direction and then the next day? So we allow with the head and neck immobilization systems about a 2 millimeter movement of the patient from day to day between the treatments and during the treatments. And we do take images before we push the button to let the protons go to verify that the patient is in alignment in the correct position.
Ah, I see.
We have two-dimensional KV X-rays images that we compare and match to three-dimensional reconstructed radiograph from the CT scan we did for treatment planning. The robot has a 6-degree of freedom table that can move and rotate the patient to get it into alignment so we know they're in the same position they were when we planned the treatment. And then we do weekly CT scans to see if there's any difference in the tumor changing size or shape or the patient external contour changing.
For any of the patients who have gotten proton treatment, you probably remember that you're in the room for about 15 minutes and the treatment is only happening for about 2 minutes, and you kind of wonder, well, what is going on? What is going on is the setting you up in absolutely accurate position, the position you had your treatment planning. And as Rob mentioned, diagnostic X-ray quality films are taken in 2 directions, and the therapists have a printout of what the field should look like, and they match that. The tables have 6 degrees of freedom so that you can realign the patient in the same position they had their treatment plan for CAT scanning. Now that system works very well for tumors where you're basing it on bony anatomy, skull base, spine. For soft tissue tumors, the visualization is not as good, so facilities are now adding what's called cone beam, basically a CT scanner inside the room to improve the visualization. There is some margin for error, and there is some uncertainty in the proton range because we use CAT scans to plan the treatment, and we have to convert from the X-ray absorption to proton stopping powers. There's a nomogram for that. For patients when we're treating in the chest or the abdomen, we do what are called 4D treatment planning CAT scans. We capture an envelope of motion that captures the trajectory of the tumor, and we treat that. We did some studies in terms of once we have a patient on the table, how much they move during the treatment. And for the spine tumors, at least in the mobile spine, it was up to 3 millimeters. So we add a little bit of margin for motion. So these are all sort of goes into the treatment planning. But again, I think it emphasizes, as I mentioned before, There is a big advantage in seeking treatment in experienced centers, and two people may have the same equipment, much like Dr. Rose and I would use the same scalpel, but you would want him to operate because of his experience as opposed to me. And two places may have the same proton facility, but if someone has not treated chordomas, for example, they will not, a physician has to draw what needs to be treated. We outline the area that need to be treated. Some of it is tumor you can't see based on your understanding of where the tumor cells are. And that is purely based on your knowledge of the tumor and its natural history. And in our field with the technologies where the radiation dose is being delivered, if you don't include an area, it does not get radiation treated. And if you're missing the tumor, there is a 0% chance it's going to work. And so, again, this is all based on experience and expertise. And this is no different. You bring your Mercedes to the Mercedes mechanic. You don't bring it to the Yugo mechanic. Someone is used to working in an area, they get expertise. If someone asks me, am I better at doing this than I was a decade ago? Absolutely. If someone asks Peter, is he better operating now than he was a decade ago? Absolutely. Have I learned from my mistakes? Yes, I've learned from my mistakes. One of my the head of the radiation oncology branch at the National Cancer Institute some years ago, Eli Gladstein, had made a comment. He said, I've made every mistake you can make in this business. I've just tried to not make the same mistake twice. So you learn, experience is important.
Wow. That is comforting for those of us who have gone under radiation. Especially after all the talk this morning about reoccurrence. And as I was sitting back there, I thought, oh my God, I forgot about that. And then I started thinking about the dosing algorithms that Dr. DeLaney talked to me about some time ago. So I want to make sure this question was in here. I've had another, is there another slide, Ruth? Are we cool in slides? If there is, flip it up. We're okay? We're done. One slide. Great. Okay. Next question is high dose and hypofractionated radiation. If the radiation oncologist would define that for us. And then the second part of that question is the decision to use one or the other, is that up to the oncologist, or is that a patient, or is that a decision made by both of those individuals?
I can start with this, and Rob may have some comments as well. Hypofractionated radiation refers to large radiation doses, and given one or perhaps up to 5 radiation doses to deliver focused high-dose radiation to a very small volume. And this was really developed initially out of the treatment for metastatic cancer to the brain, and you would deliver such a high dose to the very isolated area, you would completely ablate, completely necrose that small tumor nodule. And then it was adapted for stereotactic body radiation, and it's now an option for early stage lung cancer as an alternative to surgery. And you completely necrose the volume that you treat. And this is also used for lesions in the liver, for example. And it has been used for patients who have metastatic cancers to the spine with a very high degree of precision to avoid delivering too much dose to the spinal cord. One concern is that many of the patients who are treated for metastatic cancer to the spine have a limited life expectancy, and large radiation doses to nerves can produce late neural injury. And so I think if one is using large hypofractionated radiation doses near nerves or the spinal cord, there is the risk of a late injury. There's also risk of late injury to adjacent tissues, of injury to the esophagus, for example, if you're treating the mobile thoracic spine. And that can have unexpected side effects. So I think this is something, if one is delivering higher radiation doses to the central part of the tumor, for example, that's a strategy. I think it requires further study for chordomas because the tumors arise close to critical spinal nerves, critical cranial nerves, critical sacral nerves.
I don't have anything to add. Certainly the complications related to radiation therapy are related to the dose per treatment. And so the lower the dose per treatment, the safer it is when we're thinking of nerves, cranial nerves, and brain and brainstem and optic structures. So the safest is a small dose per treatment, not a large dose per treatment. If you could isolate the chordoma from the brain and the nerves, then it would make a lot of sense. But and we try to do that, but most of the time it's anatomically impossible. But as Dr. DeLaney said, it is possible to put a high dose per treatment right in the tumor itself and have a low dose per treatment on the periphery close to the nerves.
A question from the audience, and radiation only. Does that affect the possibility of having salvage surgery for reoccurrence?
That's a good question. When we recommend or agree to treat with radiation alone, we recognize that currently there's probably at least 15% of patients who are going to have a local recurrence. Some of those patients will also have metastatic disease, in which case you're really going to focus on systemic treatments. But if someone has an isolated local recurrence after high-dose radiation, the risks of surgical morbidity are going to be higher. Now, often these are patients who already have upper sacral tumors, so that it's sort of a given that the salvage surgery is going to entail loss of upper sacral nerve function, but wound healing can be a significant issue, and as can the complex reconstructions that are required. They'll have a higher rate of failure, which again is, at least in the long run, why we're looking to, if one is using non-surgical treatments, to try to improve their effectiveness, whether it's adding systemic treatment, targeted agents, immunotherapy, or some combination of them, because whatever treatment we choose, we want to make sure it's as effective as possible. And again, one learns over the course of time. When I first was treating these patients, there was sort of a given that everyone has surgery and you decide on having radiation afterwards. Well, when we look at our data, that we have extremely high rates of local control with a combination of pre-op radiation and surgery, and we're maybe batting at 85% with radiation alone at 5 years. And then you look at surgery and post-operative radiation, we're batting about 50%. So we have at least, those are sort of patients selected differently, but again, how the treatments are sequenced, as well as the choice of treatments, may have an impact on the outcome.
I'm going to move on to the next section, medical oncology. And these questions will have to take the lead on our ever so patient, Dr. Wettstein, Dr. Okuno. As a chordoma patient, we hear a lot about personalized medicine. As this morning, the word was used, individualized medicine, precision medicine, genomic medicine. What in the world do all these words mean? And do they mean the same thing? And how are they related to the chordoma patient?
Well, they are all asking the same type of questions, and that is, what is the genetics of the person? What is their capability in immune terms of an immune response? But very importantly, they're asking questions about the tumors, not only the primary, but potentially stem cells that could lead to metastasis. And what you're trying to understand is, what are the genes that are turned on? And how many cells, let's say, in a tumor have those genes turned on? What's the diversity within the tumor? And what are the proteins that are turned on? Are they proteins that you can target? Are they proteins that are going to inhibit the ability to respond? It's getting an individual, that is a patient and tumor, analysis to tailor your therapy. I brought up the issue of HLA deletions, that if you have an HLA deletion, homozygous, you cannot, your cells cannot, that tumor cannot present antigens to T cells. So it seems that you don't want to enroll such a patient, at least to me as a scientist, in an immunotherapy trial with a vaccine, because that vaccine may be incredibly efficient at generating cytotoxic T cells, but they don't have a target they can see. And so not only do you have an ineffective treatment, but then you have a time delay as you assess, what did I just get done? And perhaps this person cannot be, as effectively treated with an alternative. And so you lose in both ways. And that's the importance of individualization, is getting the best possible analysis of the tumor and the patient, so you can tailor, if possible, your treatments.
Any more comments?
I'll just make a comment that most of the time when we're seeing a patient with advanced disease, we historically just say you have chordoma and treat all chordoma patients the same with a drug. Individualized medicine is actually, as Peter said, taking your tumor, seeing what DNA is in that tumor, and maybe checking 900 genes, 600 genes, or whatever. And if your tumor has some DNA damage that we can leverage with chemotherapy, we will treat your tumor with that chemotherapy. If the patient next to you doesn't have that genetic mutation, we won't treat that patient with a specific drug. So it's really looking at specifically at your specific tumor and seeing whether or not we can target a drug towards that. Unfortunately, at this time, you might have specific targets, but we don't have any drugs that can leverage those targets. And we at this time do not know, because your tumor has this target, whether or not you can actually respond to that individualized targetable drug. So that's where Josh and his team have to really look hard, that there are more than just those targets that we're looking at. There are immune issues with it. As you heard earlier today, it's just not your tumor, it's your host. It's all the cells around that tumor that play into this as well. So the more we know about not only your tumor, your immune system, or all the normal cells around it, we can only then start to tailor more specifically those treatments for you.
I was a history major in college, and it's worthwhile for just a second to just review some general oncology history. One of the most curable treatments, or one of the most curable diseases we treat with chemotherapy is lymphoma. And when lymphomas were first treated with chemotherapy, they were treated with a single chemotherapy agent, and the tumors would shrink, and then some months later, they would regrow. And over time, what was developed were combinations of chemotherapy targeting multiple pathways, and you moved from tumors that would shrink and come back to tumors that would shrink and never come back. And the reason I mention that is what Dr. Wettstein had mentioned earlier. Tumors are very, very resilient, and what we've seen, even for some of the most responsive tumors, there's a tumor called the GI stromal tumor, which is one of the tumors that was first treated with a targeted agent targeting the tyrosine kinase pathway, that the tumors would often develop resistance over time to a single targeted agent. And some of the strategies for overcoming that, at least some combinations of targeted agents and radiation where the radiation is very physically localized, but will hit multiple pathways in the tumor when combined with a targeted agent, makes it harder for the tumor to escape from a block of a single pathway. But ultimately, we may be relying on, if you're using targeted agents, multiple targets, or using an immune response where you're in fact activating the entire system.
One should also consider that within a tumor, there is diversity in cell types. That goes back, I think the gentleman left the Kansas question. If Kansas is all that's left, you need to not only know the original genotype of the tumor, but you also need to know what is different with who's remaining. And you then have to not just tailor to the first, to the primary, but to the recurrence as well. And it brings up, there's just so much more complexity. It's complexity in how you analyze tumors in patients and how you analyze what happens after therapy. And all of that comes at a cost and with time. And complex situations such as this, where the tumors have a lot of chances to thwart the host, just makes things much more complicated. It's not that they can't be dealt with, but you have to go into it knowing that you're dealing with an evolving organism, if you will. And you give it the chance, and it will evolve, if it can.
There's information, at least even before therapy begins, that because tumors are genetically unstable, that the progeny acquire mutations such that even, there was a paper in the New England Journal recently looking at a patient who had a primary kidney cancer and metastases to the lungs. And even within the primary tumor, the mutational profile was different in different quadrants of the tumor. And then the lung metastases had different mutations, some of which were shared by the primary tumor, but some of which were acquired after they'd metastasized. So you get a sense of, as I say, a very resilient tumor in many cases. That's a challenge, and I think that is why some of these tumors have been so difficult to control.
The next question on tumor profiling test. When is it suggested that chordoma patients should seek profiling, and how and where do they go to get the profiling? And is the profiling going to be effective now that we know that these tumors are so dynamic?
Typically, what we would say is, if you're going to embark upon treatment, it's probably good, or at least to consider at that point, getting your tumor profiled. That's assuming that if you're going to profile the tumor, that you're going to rely on the data to treat you. So if we profile your tumor and there are no targets, are we still going to treat you? If we profile your tumor and it suggests that using a drug that we're not even thinking about, not even FDA approved, not even reimbursed, are we going to treat you with that? We don't have data right now, even if you profile your tumor and it suggests that it's a topoisomerase 1 inhibitor, that actually treating you with a topoisomerase 1 inhibitor is actually going to work. It might work in maybe 20% of the people. Are you going to be that 20% of the people? So generally, if we're not, usually we're not recommending profiling your tumor at original time of diagnosis, because at original time of diagnosis, they're going to be radiating, operating, or some combination. Down the road, if your tumor recurs or spreads, Dr. DeLaney said about 30% will metastasize. Maybe at that time, it's worth profiling your tumor, because your tumor now is totally different than it was 10 years ago. fact, your tumor now is different than it is 5 minutes from now, maybe then 10 minutes from now. So we really don't know when's the right time to profile your tumor. But you have to realize right now there are many companies out there that can profile the tumor. The big ones are Foundation One and Caris. There are other ones in the Boston area. They're all trying to figure this out. Nationally, there is a national study through the cooperative called the MATCH trial. And the MATCH trial is taking your tumor and seeing 23 drugs that might be available through the NCI. And if you have a match, you'll go on that drug. Right now, we're finding that probably about 25% of those individuals will have a match. That's specifically to answer the research question. Your tumor has this vulnerability. We actually have a drug that's targetable. We can match you up and treat you and see how you do. And that's ongoing right now. And many of our patients that are trying to get on these studies because we have different drugs that we might want to try that are actually a match.
What it's saying is, until you do the test, theoretically, that tumor should respond. Because genotypically, it says it should, but what if it has other compensating factors that override, let's say a tyrosine kinase, and it has another tyrosine kinase that's upregulated? Does it will the second gene override the first? I think for banking, for me, it's simply gathering all the data, or at least the tissue that will get you at some point the data that you can, without intent to treat. So if you want to know what the meaning of the metastasis genotype is, you need to have the genotype of the primary and segments of the primary.
So I would echo that point. For research purposes, we should profile every time you have a tumor. And if Josh and his team can help afford that and do that, we'll have this database later on. But individually, how we treat individuals based on the molecular profiling, it's still research. But I would agree, if we have the luxury and the ability and capability to profile every time at primary diagnosis, at first metastasis, second metastasis, before radiation, just like Peter said before, I think that will give us a lot more information as we build up the research portfolio.
So, as a cynical old man with sacral chordoma, it sounds to me like precision medicine is not very precise. It sounds to me it's more like a moonshot. We're not there yet, are we, fellas? Dr. Okuno?
No, I mean, I think that's the hope and promise of all us. We're at to be, not pessimistic, but also be optimistic. We're at a forefront that we didn't have before. For us to do profiling of the tumor, we used to do one gene at a time. It took forever. Now with one little drop of a tumor or blood, we can profile things very, very inexpensively. What is inexpensive? Maybe a couple $1,000 compared to maybe $10,000 per gene in the past. The speed at which we're going is much faster right now. We don't need big chunks of tumor anymore. We can do it on a paraffin-embedded tissue, which is small little pieces. We're talking about molecular profiling your tumor, but what about all the protein RNA that is being developed as well? That has to be on the fresh stuff. It has to be fresh frozen because proteins degrade very quickly. So we're starting to develop this technology that is going to be individualized. I think the teams that are being formed are starting to develop clinical trials to start answering some of these questions. The more you dig deeper and deeper, it's like peeling an onion. There's just so many more layers of why things work and why things don't. And you need to kind of remain focused because otherwise you're going to be going down many rabbit holes. Historical known, medical oncology has gone down many rabbit holes. And many of us do know in the 1970s and 80s, immunotherapy was the biggest thing in the world. 30 years later, guess what? Immunotherapy is the biggest thing in the world, right? Because
a lot of talk, very little action.
Yeah. But now, I think 30 years later, now none of us have 30 years to wait. I'm looking around the room, many of us do have 30 years to wait, but we want to be quicker, faster. That's what Josh said very quickly.
Yeah.
We only have a limited amount of time, a limited amount of resources. Let's use our time and resources appropriately and study the right things at the right time.
Well, I think this confirms Josh is right. We need a sense of urgency. Let's move on. This is a hot topic, is a question in the audience, and is a hot topic on our Chordoma support group. And I was asked about where some of these questions came from today, and I realized that there are some people in the room that don't know about the Chordoma support group that we have. It's a large group. There's 1,553 people on this site, and it's folks whose lives have been altered by chordoma, patients, family, friends, caretakers. And they do a tremendous job of communicating with one another and trying to figure out what's going on and communicating with the Chordoma Foundation. And they have 3 administrators on there. One of them is Sharon Berlin from New York City, and Chris Jones. And the third one, I believe, is Bill Dorlin. And just a shout out to Bill and say that your courage is our inspiration. These people, this Sharon Berlin is an exceptional individual who donates a lot of her discretionary time to helping us and helping the Chordoma Foundation. And I believe she's on one of your councils. Yeah. So that's where a lot of the questions come from. And the next one, this topic is a hot topic, and there's a lot of chatter about tyrosine kinase inhibitors, Metanib, or Gleevec. And the questions they have is, you can imagine this patient goes and whatever the situation is, and this drug may be offered or it may not be offered, and everybody's wondering what in the world's going on. So the question is, when would you prescribe it, and is it always the first-line drug that one would use?
So the drug imatinib is a tyrosine kinase inhibitor. It has a real good side effect profile. We've used it for chronic myelogenous leukemia. As Dr. DeLaney said, we've used it extensively for gastrointestinal stromal tumor. It's used by a lot of oncologists deal with sarcoma, so that we have a good understanding of how to use that. In addition, imatinib, or the trade name Gleevec, now it's generic, so you might be getting imatinib, is a drug that does have clinical activity against chordomas. If it were the best thing in the world and 100% of the patients taking Gleevec or imatinib are cured, I would be up here by myself. I wouldn't need the surgeons. I wouldn't need the radiation oncologists. So at this point, because Gleevec is active for a limited amount of time, we usually start out with that because we have a good preference for it. But as Josh said, imatinib is not the only drug, because eventually imatinib is not going to work. So if imatinib is not going to work, what are we going to use next? Then patients come to us and say, well, is imatinib the best first drug to use? Should I use temsirolimus? Should I use nilotinib? Should I be using lapatinib? Should I be using erlotinib? Now, these are all nibs out there. These are all words out there. But once again, we say to ourselves, if any one of those were the best drug, we wouldn't need 5 different options. So at this point, I don't know what's the best first drug. That gets back to the precision medicine. If I knew for sure it was the best drug for you, we would be more comfortable. Unfortunately, we don't know. So we have a list of 5 or 6 drugs in our hand that we just start working through. And it's only when we think that the cancer is not going to be controlled by surgery, radiation, where you know that these spots are growing, causing problems, that we would intervene. These drugs are around $10,000 a month. So these are not inexpensive drugs. Even though I say there's a good profile of them, there are some nuisance side effects that do come to people. But this is why we have to understand is that, can we leave tumors that are recurrent untreated? How comfortable would you be if Dr. Sim, Dr. Rose does this good surgery, Dr. DeLaney does the radiation therapy because you live in Boston, 10 years down the road, you get 2 or 3 spots in your lung. Maybe the best thing at that time is not to give Gleevec. Probably the best thing to do is surgically remove those. So it all depends when to use them at, and if you need to have some people around that kind of understand when is it appropriate to use Gleevec, when is it appropriate to do radiation, surgery, or some other techniques.
But as I argued this morning, one thing to consider is that you need to apply multiple stressors at one point, not wait until the population size comes up high enough that it can effectively adapt to the next round. Because then you're just chasing drug after drug. One works for 5 years, then the cell number comes up, then you do another one, and you just keep going from one to another. But how you make that initial choice for multiple drugs, that's the hard question.
So when we were trained in medical oncology, we always thought exactly what we're hearing today is you got to hit the tumor with multiple pathways the best you can. When you start hitting multiple pathways, you might be able to kill 20% here. The next pathway, you might kill another 20%. You just keep killing. And eventually, if you get a lot of 20%, that adds up to 100%. But as you're adding more and more drugs, guess what's happening? You're getting more and more side effects. So that has been tried a lot in oncology. For a very chemosensitive drug such as small cell lung carcinoma, we used to think, let's use every single chemotherapy we had, give them the, quote, the kitchen sink. That might be better than not. And unfortunately, that hasn't borne out. Why? And I think Dr. Wettstein said it, is we're really hitting with 5 different drugs the same target. We're not really hitting different parts of the tumor. We think we are, but we're hitting like, you know, the alley and the house and the window, but we're really not getting the neighborhood. We have to be a little bit broader in our drugs that we have. And today we have better drugs. Should we be giving the kitchen sink now? Should we be giving erlotinib, an mTOR inhibitor, afatinib? I mean, that sounds good, but you're leveling a lot of toxicity. So we've been here, and most of us here at Mayo Clinic has been very aggressive at surgery and ablative therapies. Whenever we see something that's reasonable to ablate, within reason, we'll ablate them. Get them to the lowest amount. Have we been willing to put someone on additional treatment afterwards, after it's been ablated? Sometimes yes, sometimes no, depending on the situation.
But it also comes down to choosing the treatments as close to tumor specific as possible. Your example of chemo drugs is a great example, but they hit a lot of things that you don't want to hit. And the trick is to identify the stressors that are tumor specific. And that's where you get to the immune system, which is designed to be antigen specific. If you can select an antigen that is only expressed on the tumor. And that's difficult to do in and of itself. Melanoma is a good example of it.
For patients, when they do develop metastatic disease, it might be worth spending a couple of minutes in terms of how we think about treatment. The patients, when they develop metastatic disease, can recur in the lungs, which, at least in my experience, is generally the most common site. They can recur in the bones. They can recur in lymph nodes. For some other tumors, other primary bone tumors, chondrosarcomas, osteosarcomas, Ewing sarcomas, if patients recur in the lungs, they often can have curative treatment with surgery. My experience with chordoma is most patients have what we refer to as miliary spread of tumor. Miliary actually comes from millet seeds. It's Minnesota, they may know what millet seeds are. They're very small, so that you see, the harder you look at the scans, the more nodules you see. So at least in my experience, we have uncommonly used surgery for metastatic disease to the lungs because they're often multifocal and you can't really cure with surgery. Bone metastases, patients can have a limited number of sites that you can palliate well with radiation or prevent a prevent a problem, or you can ablate them with other interventional techniques, microwave ablation, cryo ablation. When patients develop metastatic disease in the chest, for example, the disease is often very slow growing, maybe very small when detected, and sometimes we'll do serial scans to get a sense of what the pace of the disease is before we decide to do any treatment. Again, when you look at medical treatments, you have to decide, well, is the curative treatment available or non-curative treatment? And if there isn't curative treatment available, then what's the goal of the treatment? So if you have nodules in the lung that are very small and they aren't causing symptoms, which they almost never do when they're small, we'll initially observe people with serial scans every 3 to 6 months, see whether they're changing, and often you want them to have a size that's large enough that you can reproducibly measure the tumor to see if it's responding to a therapy. Many clinical trials, for example, require a tumor, a measurable tumor that's at least 1 centimeter in size, at least for some of the investigational agents.
It would seem to me that if I was going to go for definitive therapy, whether it's surgery or radiation, that I should get a prescription for this from Dr. Okuno first, so I can weaken that tumor, make it maybe perhaps a little hypoxic, and then nail it with surgery or radiation, which might be more susceptible to the primary treatment. Or
So if you want to fund that study, that'd be great.
I'm not doing the study, but I'm willing to fund myself for it. In other words, is the drug benign? That's another question. Is the side of it, or is this something that we better be careful with?
Well, we heard earlier that with good, appropriate selection, surgery alone might be all you need. Cure rates are good. We also heard that in selected individuals, surgery and radiation, either pre-op or post-op, cures a good amount of those individuals. In fact, we also heard that with radiation alone, in the right type of patient, might be curative of itself. And Dr. DeLaney said only about 1/3 are going to recur with metastasis. So 70% are never going to metastasize. But I have to treat 70% with imatinib, if that's the drug we decide to use, that never needed it. Spending $10,000 a month with nuisance side effects, with no good proof that it's going to do that. Now, I think it's worth studying if we can figure out who are those 30% that it's going to recur. Metastasize, I apologize. Or if we know that Dr. Rose and Dr. Sim are going to have it's a big tumor, there's a high chance of local recurrence, even with surgery and radiation, you're at that 50% range. Maybe we're willing to treat with chemotherapy, whether it's imatinib or some drug, because that's a high enough risk to justify over-treating some of those individuals with nuisance side effects.
One of the questions from the audience was, how does an oncologist define the term cure?
I will say, well, we never say you're cured, okay? Because you heard earlier on, if you follow people long enough, it's not just 5 years. For chordomas, you have to follow maybe 10, 15, 20 years. And in fact, some of the decisions that are being made today by the surgeons and the radiation oncologists is to say I'm thinking you're going to be here for the next 15, 20 years. I don't want to do something bad today that's going to affect you 20 years down the road. But that's what chordoma is. It's a lifelong wait and see what's going to happen. So for chordomas, for most sarcomas, we never say never, but as you get further and further out, the risk becomes lower. So I rarely say you're ever cured. 5 years is just because that's where professorships have to be, and that's how long you can follow people. Maybe from the head and neck standpoint, any thoughts of how you define cure?
Well, I agree. There's some chronicity to, this tumor among many other head and neck tumors. You have to be careful how you talk with patients and make sure that that you are giving them appropriate expectations. As far as chordoma is concerned, we oftentimes are faced with a lot of variability in the initial tumor presentation, right? If someone's got a tumor that's extremely amenable to transnasal endoscopic resection, and we feel like we were able to, we can't get around it, but we can debulk it and then kind of drill out the cavity where the tumor was in the clivus or that area. And they get postoperative radiation, 5-10 years out, we can see people with no evidence of recurrence. And that actually, the percentage for patients treated with initial surgery for skull-based chordoma followed with radiation, when they get a total resection, is actually the recurrence rate is very low, that being at 5 to 10 years. So it depends. I mean, oftentimes the clinical definition of cure is at 5 years, but for tumors that are a little bit more insidious, this tumor being one of them, another example being a tumor like adenoid cystic carcinoma of the salivary gland, if you follow anybody for long enough, you're going to see it come back. The question is it going to come back in their lifetime, I guess is the right way to put it, And is it going to impact their quality of life such that it'll dramatically change their life from now until the time they die from something else,
I would echo that. I mean, I think the simplest definition, the tumor never comes back. On the other hand, when this epidemiological definition of cure is when the survival curve matches the age-matched population. Because unfortunately, all of us are going to die sometime. And so if you look at survival over time, it is going down. But if you are able to have the survival of a chordoma population match that of the age-matched controls, then you're technically curing. But that also needs to address the fact that to have that match the age-matched population, it means you're also not losing patients to side effects of treatment, and there can be late side effects of particularly the medical and the surgical. I'm sorry, the medical and the radiation treatments.
We have a chordoma patient in the room who was a patient of Dr. Ed Laws, a neurosurgeon here at Mayo. And 1982, he had a clival resection. He's symptom-free, no mets, no reoccurrence. To me, that's a cure. Any disagreement with me?
Dr. Laws is an excellent surgeon who's still operating.
Is he still operating?
I think he's retiring this year, actually. He's at the Brigham right now. It's interesting. I think it's the interpreting some of the older results of chordoma resection. I don't want to throw a curveball into all the discussion today, but just 3 years ago, at least in head and neck and at least in the clivus, they've actually introduced benign nodal chordal cell tumor into the clival literature, which it's hard to know sometimes, what cures were really achieved in some of those patients. And I think, unfortunately, we're starting to view some of the literature as a little bit more dirty now, in terms of some of the things that we thought we were curing as chordoma may not have been. And that's also another fly in the ointment. I'm not saying that that's what Dr. Law's what this case could be, but I'm saying that it's going to open up a lot of thought-provoking things, I think, for the future for us in this panel. When did they introduce benign nodal chordal cell tumor for sacral tumors?
There's a lot of reports in some of the skeletal radiology literature. There's probably the first case where there was a relationship. It was in the sacrum. Was about 15 years ago from Japan, Yamaguchi.
Yeah, so you have to be careful that some of these recurrences are not necessarily recurrence of the chordoma, but these other benign things that are a little bit farther up. So you probably need to confirm because it muddies the water.
This is a hot topic again. Biopsies. When should the biopsies be performed, and how can they be performed safely so that we don't have tracking? Dr. Sim's slide that he showed up here early on for years ago when they used to do biopsies and you saw the tracking of the tumor along the position of the needle. Some of those biopsies at that time were transrectal years and years ago. Dr. Sim?
Yeah, exactly. Exactly, so I'm going to have Dr. Rose to answer this question.
I think in 2016, there's very rare, if any, indications for anyone to have a classic open surgical biopsy. Chordoma is one of the most implantable, if not the most implantable tumor that we commonly deal with. You can read cases where that they talk about doing a chordoma surgery and they harvested bone graft, and next thing you know, there's chordoma growing out of the bone graft harvest site that's 12 inches away on the patient's body because it was tracked on the instruments of the surgeon's gloves. So this is one which is, you've got to treat it almost as if it's radioactive. And so I think it goes to the issue of trying to establish where treatment's going to be for somebody. And there's a successful outcome for a patient with chordoma hangs with so many small subtleties in the balance and so many easy ways to fall off a proper treatment path and very few ways to salvage that if patients fall off that pathway. And so, as Dr. Lennon said earlier, two places may have the same machine, but it can matter a lot for radiotherapy, the experience of the person wielding it. It's really the experience of the center in dealing with something like this. And so it's not just that you do a needle-guided biopsy. You can get needle-guided biopsies all over the place. It's that someone knows to use coaxial needle sets so that they have a sheath to track along the way, but more so that the biopsy is done in mind with how the thing's going to be taken out. And no one's invested in that to the extent that the patient is and the folks who will provide the ultimate treatment is. And so I guess my only thought about biopsies would be certainly they're critical to understand. You've got to know what you're treating so you can treat it properly. But there's very specialized centers, and the good thing is that there's great centers all around the country, but it's important to be treated from the initial evaluation at a center with a lot of experience in that. And again, the good news is there's lots of great places all around the country that can do that. But once you fall off the beaten path, it's virtually unsalvageable.
I would echo what Dr. Rose said. There's in the orthopedic oncology literature, there's a very well-known paper from the 1980s by Henry Mankin, who was the chief of orthopedic oncology at Mass General, called The Perils of the Biopsy, and where patients had inappropriately placed biopsies that compromised both the opportunity for cure, but also in patients who were having, these patients having surgery, the functional results as well, because they'd open up tissue planes. Would echo that the appropriately directed core biopsies are critical, and that even the placement of the needle is critical. And again, for these tumors, I think that should be done by centers where experienced in the biopsy. These tumors have a characteristic appearance on imaging studies, and I think again, there's usually not an urgent emergent issue for most patients. The biopsy should be done by the center where the treatment is going to be done, ideally.
So, if I understand this correctly, one should go to a center that's treats chordoma, and the biopsy would be performed by an interventional radiologist that would be, for instance, CT guided. Is it that's how it's done?
In the spine.
Not in our case. And just to get onto that topic, there are certainly, so we actually get a lot of people referred to us with T2 signal changes in the clivus that are not chordomas. And there are a certain proportion of patients that we'll watch that were found asymptomatically. And as I said, there's 2 other pathologies that can confuse us. In fact, there's 3. And in the skull base, we're actually been looking at this the last couple of years. There actually are some mimickers that may not be confusing when the tumor presents as a large tumor, but as a small tumor, they certainly are confounders like chondrosarcoma, echordosis, and benign notochordal cell tumors. And some of these, we don't know the natural history of them. Now, before someone asked about so just radiating a tumor that we think is a chordoma, as I understand the sacral literature, there's a role there. In the clivus, because of these confounding other types of tumors, there isn't really that situation, nor do we very commonly use a CT-guided biopsy for these tumors. We actually, most of the time, do the operation with the intention to treat these all at once if we're going in. Again, just because of the confounding pathologies, it is really critical, I think, in our head and neck patients that we get a biopsy. I think it's very critical.
That's very helpful. Another question, and this is on radiation oncology. Radiation necrosis. Can there anything that we can do to prevent it or minimize it?
I think the best way to prevent it is to be treated at one of these centers of excellence that know what they're doing. When you say radiation necrosis, since I'm a head and neck radiation oncologist, I'm thinking of brain necrosis or brainstem necrosis. And the way to prevent that is to minimize the total dose to the brain or the brainstem, minimize the dose per treatment to the brain or the brainstem. And in the cases that are not, the surgeons are unable to completely remove all the chordoma, they play a highly valuable role in debulking the tumor, moving it away from the brain and the brainstem, and keeping it in position so that we can safely treat the skull base without worrying about the doses to the brain and the brainstem. So it's treatment planning. It's multidisciplinary imaging. It's multidisciplinary treatment. The surgeons, the radiation oncologists working together. From a patient's perspective, we heard earlier today that hypertension also can increase the risk of radiation necrosis, as can diabetes. And so you'd want to make sure that those comorbidities were well managed too, in addition to the very detailed treatment planning.
I have a flashing red light up here, which I'm going to ignore. Yeah, yes, we will. This is a question that all of us have. Scans and MRIs, is there ever a time when we can stop and we don't need to do them anymore?
I can feel it for head and for skull base. At least for skull bases, we've heard the chance for, we're always looking for the recurrence, and I think we weigh it oftentimes with the patient, to be quite honest with you. Some patients really feel more comfortable getting very frequent repeat scans, and some patients don't like that feeling of walking through the door and having that unknown answer on the other end of that scan. So I actually very much individualize, especially if we get out more than 5 years with no evidence of recurrence, and I talk to the patient about when would it, I feel comfortable backing off another year sometimes. And what I do typically is very frequent scans early on, 3 months, then 6 months, 6 months, 6 months, and then probably a 9-month scan, depending on the patient, and then a couple of years, and then we're out to 2 years, and to just slowly expand that time interval. But I do talk to the patient as we go along, here's the risks and benefits of not getting an interval scan, but I haven't met a lot of patients that we haven't been scanning long term with chordoma.
We look at chordomas in the sacrum and in the mobile spine. The greatest risk of recurrence is within the first 2 years of treatment. Approximately half of recurrences occur within the first 5 years. And so I think there is a role, presuming that patients obviously sought active treatment in the initial disease, that there would be further active treatment if there's a recurrence. So based on the presumption that you're going to act on data that you find, then during the first 2 years is the greatest the highest risk time frame, and so we typically scan patients approximately every 4 months during that time frame. As you trace out beyond that, experience has shown it's safe to extend the interval for scans. Given that half of recurrences happen after the 5-year mark, in the sacral and the mobile spine population, I think it's very reasonable to follow those patients out through at least 10 years. But clearly, the farther you are out with no event, that being no recurrence, if someone's 9 years out, have never had any recurrence, that's the best possible prognostic factor, that at 10 years they're going to be clean. But if recurrence does occur, obviously that's a difficult thing for everybody. The treatment for that is pretty difficult, but the treatment is certainly easier if it's caught at an earlier time frame than if it's caught in a late or neglected fashion.
We have one more question, but before I get to that, if you have a question that was not answered, get a hold of Shannon, and she'll help you out to find the answer. I'm not suggesting that she knows all the answers. That's not her suggestion either, but she knows the resources that are available. Last question. Watch and wait. Patient has a tumor, identified to have a tumor. Is it ever appropriate to just not do anything, just to watch this tumor, like you do with a MET and a pulmonary MET, you may just watch?
We've recently described an entity which is called an atypical notochordal cell tumor. This is a manuscript which is going to come out fairly soon in a pathology journal. We've kind of recognized the existence of what are called benign notochordal rests, which at first glance can simulate a chordoma, but they're just a freckle in the bone that's left over from the embryogenesis when we're all little babies growing, but they're not a chordoma. They're latent, they don't grow at all. We know there's chordomas which grow. There's recently been understood, or there appears to be an entity that has been, for lack of a better term, initially called an atypical notochordal cell tumor, which has some characteristics which make one think of a chordoma. This is by imaging and under the microscope if it's biopsied, but other characteristics which are much closer to a benign notochordal cell tumor or notochordal rest. And these appear to have an indolent clinical course, meaning that they appear to have minimal, if any, local growth potential, and they do not appear to have any metastatic potential. How frequent these are is unclear, because I think this is an entity that's just been clinically recognized, and the implications of it aren't clear. But, for example, there's a sacrectomy that I've done on a man. He's doing great. Thankfully, it was a relatively modest one. If we look in hindsight, we would now classify that, which was called a chordoma at the time, very clearly. But in light of what we've now come to understand, we would reclassify his as an atypical notochordal cell tumor. And in light of that, we would consider observation for that lesion today. The differentiation of these is fairly subtle, and these are not the large chordomas with a large extraosseous mass that pushes into the pelvis or destroys the bone or pushes into the spinal cord. So these are fairly rare lesions, but these would be ones which certainly would be a candidate to be observed, and intervention only if there was demonstrated growth or symptoms which arose from them.
So Bob, how long was your chordoma sitting there?
Pardon me?
How long was your chordoma sitting there?
2008. Yeah, it wasn't picked up on an MRI.
I guess from the standpoint of the skull base, it's a little bit of a different story, but similar as far as long-term implications go. Oftentimes, if imaging is suggestive that a lesion could potentially be a chordoma, we're going to go in and probably do a diagnostic and potentially therapeutic biopsy by hopefully doing either a total or a subtotal resection at the time of surgery. What will be interesting is to see if some of these more benign appearing histologies do impact adjuvant therapy after the fact for more benign notochordal tumors. But for us, it's a little bit different because, like we alluded to earlier, it's not really typical for us to use a CT-guided needle biopsy or anything like that. It's typically a diagnostic/therapeutic intervention where we're removing tumor to obtain a diagnosis. We use frozen section pathology at the time of surgery, and then try and remove as much of the tumor, if not all of it, at the time of our endoscopic procedure. So it'll be interesting to see how these other factors play in, though, as far as other therapies down the line.
Well, that wraps it up. Again, thank you, Mike. And Ivy, she's here someplace. Panel, you did a fantastic job, as I knew you would. Thank you.